Hey, hey, hey. So here is orthopedic and rheumatology pharmacology. So Stella is a 64-year-old Italian-American woman. She has a history of osteoporosis. She lives alone, and she lives in a two-story house. She's retired. She gets a pension check and Social Security. She makes all of her own food from scratch. Unfortunately, she fell on the way to the market. Her left leg is shorter and externally rotated. Anybody that's done pre-hospital care or had any training knows that that's highly suspicious for a hip fracture. She has good pulses, however, in her dorsalis pedis and posterior tibial. Her color, sensation, and motion are intact, and she has severe pain in that left hip now. She has good blood pressure, 120/58. Her pulse is 100, which maybe makes us think she's a little bit in pain. Hemoglobin is 11, which is a little bit down. I think of any woman that has a hemoglobin of under 12 as being a little bit anemic. We do an x-ray, we see that she's got a femoral neck fracture of her left hip. So it makes a big difference where the fracture is, what they're going to do, whether it's in the head of the femur, the femoral neck, or in the trochanters. She's admitted to the hospital. She's put in 10 pounds of bucks traction, and she's going to have surgery in the morning, an open reduction and internal fixation in the morning. So a fracture is any break in a bone. Patients will say, well, is it broken or is it fractured? In our world, it really doesn't make a difference. Any break is a fracture, any fracture is a break. And there's different types of fractures, however. Open fractures are open to the outside. Those have to go to the operating room same day. Those have to be washed out, cleaned out. Almost always they're internally fixated with hardware. The closed fracture, if it isn't open to the outside, can often be reduced. In other words, put back into position. We call that a reduction, and then put into a cast. Some closed fractures require ORIFs, depending on the type of fracture. A complete fracture is a break all the way through the bone. Incomplete is not all the way through the bone. Displaced is out of position. Non-displaced is still in position, but with a break in the bone. And comminuted means broken into a bunch of pieces. So what happens when a fracture occurs? You get bleeding at the site of the fracture. A hematoma forms. Repair cells go to the end of the bones. They form a framework. The callus then begins to form a few weeks after the fracture and develops some membranous bone, and then that is replaced by real bone, and then the fracture is then remodeled so that it looks just like it did before it was broken, if all goes well. So you have to get the bone ends back together. When I was doing orthopedics years ago, they used to tell the residents that as long as 30% of the bone is touching, you're okay. It will remodel. But you can do that closed reduction or an open reduction and internal fixation. Once you've put it back into position, if it's closed reduction, you can put a cast on it. Sometimes they even do an open reduction, they'll put a cast on it. More often, these casts are made of fiberglass. They can still be made of plaster, but that's unusual. Sometimes you put the patient in traction. Sometimes if somebody has a broken femur, it's very hard to get that figured out and get them to the OR, especially if they're medically unstable. So we'll put them in traction in the meantime. And sometimes we even put an external fixator on. I think I have a picture of one coming up. So she probably got a fracture because she has osteoporosis. And osteoporosis is substantial thinning of the bones. So it has to be more than 2.5 standard deviations below the population norm or 1.5 standard deviations below the age and sex norm. So this is definitely a substantial decrease in the bone mass. So who gets osteoporosis? People that get older, especially women. White folk get osteoporosis more than other races. Family history, if you have family history. Certain diabetes or certain diseases such as diabetes, thyroid, adrenal, or eating disorders will increase the risk of osteoporosis. What can we do to decrease the risk of osteoporosis? Well, calcium intake makes a difference, although it probably makes a difference mostly in the age of 20s to 30s. Once you're 70, it's probably not going to make a huge difference. You want to get adequate calcium so that you're not leaching calcium out of the bones, but getting in excess of the minimum is probably not that essential. Estrogen, we can add estrogen and people will increase their bone density, and there are some selective estrogens that we can use. Alcohol, you want to keep that below 2 drinks a day in men and 1 drink a day in women. People that are sedentary lose bone more. There's something called Wolff's Law that basically says the density and the strength of the bone is based on how much stress it gets. So weight bearing is a very positive thing for bones and for bone healing. Medications such as steroids or heparin can cause osteoporosis. And of course, the biggest offender is smoking. Getting up back to calcium, however, remember that adequate vitamin D is also important. I'm a little bit cynical about all of the great things vitamin D is being touted for, but bone health is real. Whether it really affects depression, whether it affects any of these other things, I don't know. Vitamin D is actually a hormone in some of the forms that it exists in, and I think that hormone is related to feedbacks and other things. So that just giving supplemental vitamin D doesn't necessarily raise that type of vitamin D level. Smoking is evil. So what can we do? We manage the diseases. We avoid medications such as heparin and steroids if we can. We increase physical activity. We try to increase calcium and vitamin D if it's not at the normal recommended dietary allowances. A number of medications can be used that will increase the density of bone. Bisphosphonate, Prolia is a monoclonal antibody that is a rankle inhibitor. Evenity is another monoclonal antibody. Evenity is unusual because it actually both increases the buildup of bone as well as slows the breakdown. Most of these other medicines actually just slow the breakdown. Another medication that's not mentioned here is Forteo, which is actually an analog of parathyroid hormone, which also builds up bone. It's very controversial because some of these medicines that slow the breakdown of bone are associated with certain type of weird femur fractures. So the bisphosphonates, the most common one used is Fosamax. It's either 10 milligrams daily or 70 milligrams weekly. Boniva is another one that's a once-a-month medicine. And again, they stop the bone breakdown. They don't increase bone growth. Prolia and Evenity also stop bone loss. The Evenity also increases bone growth. Both of these are only given by injection, and they may have some side effects associated with them. Estrogen replacement therapy is almost always done in the form of a selective estrogen receptor modulator called Avista, and that medication will help to slow the breakdown of bone. So Janice James, she's a 42-year-old woman. She's a high school science teacher. She has some vague arthralgias. She's got some fatigue, poor appetite, and general malaise. And she has been diagnosed with rheumatoid arthritis. So many of those symptoms are consistent with that. It's an inflammation of the joints. Now, a lot of people think they have rheumatoid arthritis when they don't, just because their joints ache. And arthritis means inflammation of the joints. But rheumatoid arthritis is a specific type that's associated with an autoimmune process in which the body is attacking its own joints. So how can we treat it? We can block that immune process. So methotrexate blocks tumor necrosis factor. Xeljanz actually also blocks TNF, and the monoclonal antibodies also stop the effect of the TNF. Now there's another type of arthritis that we call osteoarthritis or degenerative joint disease. And in this case, a lot of the joints get inflamed. It's basically a wear and tear arthritis. Most common joints, of course, are knees and hips, and those are the joints that we often will replace because of this osteoarthritis or DJD. those two things mean the same thing. So as we say, the ones that take the greatest stress, those are hips and knees. And so we have to sometimes replace them. And usually the precipitating reason for that is pain. So these people will be using NSAIDs for pain. Many of them will actually end up using opioids for pain, which is pretty controversial, but unfortunately they can't function unless you do. And so a lot of these people will be taking 2 or 3 Vicodin, or we usually refer to that as Norco now because Vicodin's a brand name and is very expensive. They need to have some medicine to be able to function. So these DJD patients are older, they're a bit more likely to be overweight. They're usually otherwise healthy, although not always. The hips and knees are most likely affected, but you can get DJD in other joints. A lot of people get it in their back, they get it in their shoulders. They usually have normal labs and they don't have any redness. So other treatments for DJD would be lose weight, heat, exercise, and pain medicine with everything from acetaminophen, NSAIDs, and even opioids in many cases. So always consider those potential side effects. In general, the less drug we use is better. On the other hand, you also don't want to undertreat, because if someone's in pain all the time and they can't get out and do the things they need to do, their life is pretty awful. So there's always that balance. So drugs, Fosamax, Prolia, Evenity, Premarin, which is a non-selective estrogen, very rarely used for osteoporosis, but would decrease the risk of osteoporosis if you had somebody that was on it for menopausal symptoms. Avista, which is a SERM, a selective estrogen receptor modulator, as well as the medicines that block TNF. That gives us some stuff to chew on. Let's meet more on the discussion board and maybe even a bit in Zoom. Enjoy.